Okay, Diltiazam. Diltiazam, also known as Cardizem. And you will hear it by both. Okay? So Diltiazam or Cardizem is a class 4 antiarrhythmic. Or it is also a calcium channel blocker. Okay. This is also a calcium channel blocker. Now, how does it work? It lowers blood pressure by relaxing vascular smooth muscle, and it also slows AV conduction. Okay? So it lowers blood pressure by relaxing vascular smooth muscle. As well as slowing AV conduction. How does it slow AV conduction? Well, it's a calcium channel blocker, so it's blocking the calcium channels, not allowing the sodium, potassium, calcium, all that switching during polarization, repolarization, all that fun stuff. Well, this is blocking some of that, so it's slowing it down even more. So this is also going to be a rate controller. It's not only lowering the blood pressure, but it's also slowing AV conduction, therefore slowing heart rate. Okay? So what does that mean to us? What does that do for us? When are we going to give this? Okay, so we're going to slow the AV conduction. So there are times when we need to do that, and what are those times? It's tachycardia, right? So we want to slow that rate down. What kind of tachycardia? A narrow complex. This is going to be a stable narrow complex tachycardia. Used to carry this on the ambulance. They do not anymore because it needs to be refrigerated. They do use this in the ER quite a bit. So we're going to do stable, narrow complex, tachycardia. Stable narrow complex tachycardia, or non-symptomatic SVT. Non-symptomatic SVT. Narrow complex tachycardias are most generally SVTs, right? Because they're generated above the ventricles. So supraventricular tachycardia, this is what this drug is made for. It is also made for a rapid ventricular rate or a rapid ventricular response associated with AFib. So RVR, rapid ventricular response associated with AFib. So if you have an AFib with RVR, chances are when they get to the hospital, they're going to get Cardizem or Diltiazam or Cardizem to help control the rate, to slow that conduction down and regain control. It's kind of a neat conversion to watch them go from AFib to a sinus rhythm again once that gets under control. Because this is raising the threshold for that excitability and for that depolarization. It's raising that threshold by blocking the calcium channels and not allowing the polarization, depolarization to happen as quickly, which is settling things back down. Okay? So, we're only going to use this in stable narrow complex tachycardia, or another term, non-symptomatic SVT. The reason why I say this is because this is what we've talked about in class. We've not called it stable narrow complex tachycardia. We've called it non-symptomatic SVT. So it's either stable narrow complex tachycardia, stable SVT, or non-symptomatic. I know I'm beating this down, but I want you to understand pharmacology comes first in stable patients. We do not shock narrow complex tachycardias until they become unstable. We always go pharmaceutical first in stable patients. Okay, so our dosage is weight-based again, 0.25 milligrams per kilogram IV bolus. So 0.25 milligrams per kilogram IV bolus. Okay, so what's a bolus? We're going to give that all at once. We're going to give it now, and we're going to give it all at once. Okay, to a max of 20 milligrams. So that is a max dose of 20 milligrams. There is also a slight codicil. They don't really recommend. It's in the range. However, they do not recommend. Not recommended. It's written in red. 15 to 20 milligram doses. You can go that high, but they don't recommend it. Basically, what they're saying is, if you're giving that much, they're probably still not going to come out of it using this medication. Maybe we need to consider something else. Okay? And the only route for this is IV. Well, I say that. You could give it IO. If you had to. However, this is a stable patient. You should not need to drill the bone. Okay? Because if you can't get the IV, you don't necessarily need to give it in the field, or if you don't have it to give in the field, I'm not going to drill into a bone just so the hospital get to the hospital, let somebody else make an attempt, so long as they maintain stability. If they become unstable, we have a different route for that. It's called electricity. Okay, so for our contraindications, we are not going to give this if there is hypotension involved. If they are hypotensive and they've got RVR or SVT, they're not stable. Okay, plain and simple. If they're hypotensive with narrow complex tachycardia or RVR with AFib, they are not stable. They have become unstable. That's where you're going to shock this to cardiovert. Okay? You're not going to, again, not going to do this in congestive heart failure. You could exacerbate the problem. You're not going to do this in cardiogenic shock. Because why? Because it's shock. It's unstable. They're not stable. It says right there in the indication, stable neurocomplex or non-symptomatic. If they are in cardiogenic shock or they are hypotensive, which is cardiogenic shock, then they are not stable. And you are not going to give this to wide complex tachycardia. Why are you not giving it to wide complex tachycardia? This is not SVT, correct? Where does wide complex tachycardia originate? We've just discussed this. Wide complex tachycardia originates in the ventricles or below the AV junction, below the atria. Wide complex tachycardia starts in the ventricles, and this medication slows conduction at the AV. This slows conduction in the junction. Kind of rhymed. So we are not going to give this to wide complex tachycardias. We are not going to give this to any one of these three because they're not stable. This is strictly for stable narrow complex tachycardia. This is something we need to do so they don't become unstable. What are our adverse effects? Our adverse effects are nausea, vomiting, dizziness, headache, and hypotension. Okay? Why are we thinking it's going to cause hypotension? Because it's slowing conduction. It's bringing, relaxing the vascular smooth muscle. Nausea, vomiting.